Quickly move on to Swati Singh's talk on ocular adnexa and mucous membrane pemphigoid because we are running out of time. Thank you.
Good evening, everyone. Are the slides visible?
Yes, ma'am. The slides are visible and you're loud and clear. You're good to go.
Thank you. Thank you. So I shall be taking you through the involvement of ocular adnexa in patients with mucous membrane pemphigoid. To begin with, the lacrimal gland involvement in the mucous membrane pemphigoid patient, as we have heard across the talks, that it is mainly a cicatrization process happening within the conjunctival subepithelial layer. So this is a normal palpebral lobe of the lacrimal gland, which can be seen as a convex structure having a smooth overlying surface conjunctiva with a normal vascularization. Whereas in patients with MMP, because of the progressive cicatrization, you can see that the appearance of the lobe is completely lost. It has become flat, and there is a subtle appearance of whitish subconjunctival scarring in this area, which obliterates these ductules. And as it's a secondary cicatrization process, then the lacrimal gland activity is affected, and these patients have an aqueous deficient dry eye disease. So what can we do for prevention of or preventing the progression of the scarring in these patients? We have tried periglandular 5-fluorouracil injection in these areas, and with a single dose at 2 weeks of follow-up here, you can see that there is a subtle clearing of the scarring and the inflammation in this part, but it requires repeated injections. To the max, we have given every 2 weeks 3 sets of injection of 1 milligram, and we found that the inflammation subsides to a very great level, but the secretory activity doesn't come back. There was only one study in the literature where they had analyzed the effect of direct injection of 5-fluorouracil in the subconjunctival space. They found that the end stage finding was that the vision was improved, but there was no change in the symblepharon formation or the need of adjunctive procedures like AMG, MMG for the initial shortening. And this drawback of this study is that it was a retrospective 10-year data analysis without any objective documentation of the changes at each visit. The next, meibomian glands, which are severely affected because you can see that there is a scarring which happens in the palpebral conjunctiva in the subtarsal space, which progresses onto the lid margin. The lid margin becomes thickened and there is a complete obliteration of the ductules. In very few cases, you can see lid margin keratinization as visible in this case. And then there is a metaplastic changes in the meibomian gland openings where you can see these distichiatic eyelashes originating from the openings of meibomian glands. So the dry eye in these patients is trifold. It's the affection of the meibomian glands, lacrimal glands, and the conjunctival goblet layer. Next, the eyelids, they are involved in the term of trichiasis, entropia, and distichiasis, and these are very create a very damage onto the ocular surface, and which progresses the limbal stem cell deficiency and eventually corneal scarring and keratinization of the surface. So these are very much needed, the procedures to control these manifestations on the ocular surface. So this is a case where you can see that there are distichiatic, very fine lashes. These are usually not visible without slit lamp examination. So when you see them on a high magnification, you can see these subtle gray hair which are originating from the meibomian glands opening. And there is a corresponding epithelial defect, non-healing defect onto the corneal surface. A simple procedure of electroepilation when there are only 1 or 2 lashes can resolve the epithelial damage on the corneal surface. However, the success rates in these eyes is to the tune of 50%. So when you're counseling these patients, it's better to apprehend them that they might need more number of surgeries for the resolution of trichiatic and distichiatic lashes. This was the one gentleman who was using anti-glaucoma medications for a very long period, and you can see this. The right eye has almost corneal granuloma as well as diffuse vascularization, and he was denying PL in this eye. The left eye has cupping to the tune of 0.9. This was the only seeing eye, and he had recurrent trichiatic lashes in the medial segment of the upper eyelid. He has undergone 2-3 electroepilations and was manually epilating, but was tired of it. In this patient, the medial entropion was addressed with the use of anti-laminar repositioning, but As the diagnosis was assumed to be DICC, the corneal changes, they progressed very rapidly following the surgery. So any eyelid surgery, if you're doing in a case of cicatrizing conjunctivitis, just make sure that you have ruled out MMP, as it requires a augmentation of the preoperative and postoperative steroids. So in these cases, if you are touching the eyelid tissue, they have very high recurrence rate. Even with the addition of or the modification of various procedures, the maximum success rate that has been achieved is to the tune of 60 to 70%. I'll be discussing a technique of entropion repair that we are using at LVPI. In this, the conjunctival cicatrization shortens the fornix. So we are using mucous membrane graft to address the lid margin, the bare tarsus, as well as the shortened posterior lamella in one sitting. This is a short video where I'll be showing you the upper eyelid cicatricial entropion that has been addressed with the mucous membrane graft and anterior lamellar repositioning. As you can see, in the past, the patient had MMG in the upper lid. So the upper lip was used as a donor site. We harvest a graft to the tune of 20 millimeter by 5 millimeter of the size and infiltrate the upper lip just before starting the eyelid surgery so that you have an adequate decongestion of the labial donor site. On the upper eyelid, you tie everting sutures so that you expose the whole of the lid margin. Once the lid margin is exposed, you split it at junction of anterior lamella and the posterior lamella. In most of the cases, when it's thickened lid margin, you cannot differentiate the meibomian gland opening. Then you make an incision at the root of the eyelashes. So you follow the root of the eyelashes and you separate the anterior and posterior lamella. You will frequently encounter a very scarred tarsal plate. So you have to go very slowly with the dissection so that you don't inadvertently damage the tarsal plate in these patients. So once you have released whole of the anterior lamella till the upper border of the tarsus, you reposit the anterior lamella 4 millimeter beyond the lid margin and the bare graft tarsal, the bare tarsal area, as well as the lid margin is then covered with this mucous membrane graft. The graft is anchored with the use of 7-0 interlocking continuous sutures onto the anterior edge, and the posterior edge is anchored with the use of a glue, a fibrin glue for the apposition. And this is how the post-op day 1 appearance will look like. You make sure that you have thinned the conjunctival graft quite a bit so that the appearance is not bulky. And this is a follow-up 1 month period of picture of this patient. So I'll be discussing a case. This is a lady, she was one-eyed and she was already on the oral immunosuppression and she had a severe cicatricial entropion. This was her cornea, where you can see a significant interning of the eyelashes of the upper eyelid onto the surface, which has caused extensive scarring and the vascularization. This is after the same surgery, her appearance at 2 weeks, and this is a final appearance where you can see that the conjunctival, the MMG has taken similar appearance of the conjunctiva, and after extracapsular cataract extraction, her vision was 6/60. This is another lady who was 73-year-old, and she was already on mycophenolate for MMB as well as steroid, and she had a very progressive ocular surface damage. In this patient, there was a lid margin keratinization along with fornicial shortening. She underwent lid margin mucous membrane graft elsewhere. And since the eyelashes were not addressed at the same time, here you can see she was just manually epilating those lashes, and you can see the stubs of those regrowing lashes back onto the eyelid margin. And here you can see a lash coming directly from the mucous membrane graft. So these patients very often, because of the associated already dry ocular surface, they don't like the constant irritation caused by these misdirected lashes. So whenever the patients are not amenable to any electrotherapy or manual epilation, we advise the surgical procedure for these eyes. So in this case, the lower eyelid was managed with the same technique, and we excised lid margin, and that was sent for the histopathological assessment, where you can see extensive fibrosis. This is the old mucous membrane, and you can see extensive fibrosis occurring in the tarsal plate, which has completely damaged the meibomian glands as well. Now coming to the symblephrone, in these patients, we only touch it because if they want to fit the pros lens or the scleral lens. This was a one case where you can see ankyloblephrone on the medial edge, and it was completely fused onto the underlying bulbar surface. So there was no medial and inferior fornix in the nasal segment. In this patient, bulbar mucous membrane graft was done, and after the bulbar mucous membrane graft onto the nasal bulbar area as well as the inferior palpebral lower eyelid, there was an adequate opening and she could wear the contact lenses. So to summarize these cases, you should avoid as much as you can avoid touching the eyelids. But if the patient needs it, then you should first control the ocular surface inflammation. We usually hike up the immunosuppression as well as start the patients on oral steroids before planning any eyelid surgery. And it should be continued even after eyelid surgery for a period of 3 months. And patients should be counseled that they would require a repeat surgery, and there are high chances of association of failure with these surgeries. And in future, we plan to explore the therapy of 5-fluorouracil as an antifibrotic therapy for these eyes. Thank you.